So guys, I think the picture itself says what is today's video about. So it's about snoring and obstructive sleep apnea. We will differentiate them both in subsequent slides. So what is meant by snoring? Snoring is nothing but a sound produced during sleep, either due to many causes. What are the causes? We'll discuss it in later slides. First of all, obstructive sleep apnea, OSA. We have to differentiate between obstructive sleep apnea and snorers. Snorers without obstructive sleep apnea are known as primary snorers. These usually constitute about 25 to 50% population, and most of them are middle-aged men. In obstructive sleep apnea, they constitute about 1 to 4% of the population, and the male is to female ratio is usually 2 is to 1. Okay, not all the people who snore have obstructive sleep apnea, but the people who have obstructive sleep apnea, they snore heavily. So now we will appreciate the normal breathing, snoring and obstructive sleep apnea. In the first of all, I would like to tell that the blue color demarcation in every diagram is the normal airway. In normal breathing, the airway is normal and also tongue, soft palate and uvula are in place. In snoring, soft palate and uvula are somewhat down, so that there is some obstruction to the airway. And in obstructive sleep apnea, soft palate and uvula completely obstruct the airway, so the patient presents with apnea, difficulty in breathing. Okay, after getting some idea about normal breathing, snoring and obstructive sleep apnea, now we'll move on to mechanism of snoring. So mechanism of snoring is due to two things. One is due to turbulent airflow. Turbulent airflow is usually due to vibration of various structures like tongue, tonsillar pillars, soft palate and redundant pharyngeal mucosa. I need to show you this diagram again. In this diagram, the obstructive sleep apnea patient is having his tongue and also uvula are so wide and big so that they obstruct the airway completely. So that is the reason why turbulent airflow is maintained due to vibration of tongue, tonsillar pillars, soft palate and also redundant pharyngeal mucosa means the mucosa which is not useful for us. So we have discussed the first mechanism of turbulent airflow, which include vibration of so many structures, and the second mechanism would be obstruction from nose to pharynx. Any obstruction in the upper airway may also lead to snoring. This picture is about what we have discussed till now. The snoring may occur due to relaxation of pharyngeal muscles, any obstruction in the upper airway, any vibration of soft palate, tonsillar pillars and the base of tongue. And now the coming slide is a very interesting slide. Generally the snorers who snore very mild, the sound is up to 40 decibels, and the snorers who snore severely, the sound is up to 90 decibels. The reason why I kept the picture over there is the 90 decibel sound is nearly equal to a welding sound. That means the sound is as high as the welding sound. So just to compare, that's it. And now we'll go to etiology. Now coming to etiology, we will discuss etiology under two headings: anatomical causes and neurogenic causes. Anatomical causes are due to hypertrophy of palatine tonsil, any bulky tongue, and neurogenic causes are generalized failure of the muscles which control the upper airway. So now we'll see some pictures depicting them. Here you can see the bulky tongue obstructing the airway, and in this picture we can see an obstructive sleep apnea patient whose tongue is so bulky and soft palate also, which is obstructing the airway. And this picture is about neurogenic causes, the generalized failure of the muscle tone which are controlling the upper airway. And this is just another picture. Now we'll discuss about symptoms of a obstructive sleep apnea patient. As given over there, they are nighttime symptoms and daytime symptoms. Nighttime symptoms are loud persistent snoring, apnea, choking due to obstruction, restless sleep, and he has nocturia. He frequently visits to the bathroom. And daytime symptoms include early morning headaches, daytime sleepiness, poor memory or concentration, irritability, and even falls asleep during the routine activities. Daytime sleepiness is a dangerous symptom. It is not only harmful to him but also to the society, because he may cause accidents if he is a driver or driving a car. So we can't neglect him, we have to treat him immediately. Okay, now sleep apnea has occurred. Now what? If he is left untreated, there are so many risks of diabetes, hypertension, heart failure, cardiac arrhythmias, myocardial infarction, and also cerebrovascular accident. So now we will discuss about clinical history. What we'll ask for the patient. First of all, we'll ask about the symptoms, whether he had any symptoms already discussed above. Second thing is Epworth sleepiness scale. If the score in this scale is more than 10, then the patient is high risk to the obstructive sleep apnea. We have to go for further evaluation. What is the scale and further details we'll see in the further slides. And thirdly, we'll ask for any alcohol intake or any tranquilizer use like diazepam or any mouth breathing because they can increase the snoring. And now we will discuss about Epworth sleepiness scale. Here 0, 1, 2, 3 are 0 means if he doesn't never doze, 1 means if he slightly dozes, 2 means moderately dozes, and 3 is severely dozes. There are 8 situations. They are sitting and reading, watching TV, sitting inactive in a public place, lying down to rest in afternoon when circumstances permit, sitting and talking to someone, sitting quietly after a lunch without alcohol, and others. We will ask the patient about these situations, we'll give them a score and we'll add up all of them, and if it is more than 10 then he has OSA. Now coming to clinical examination, we have 3 subheadings: general inspection, oropharyngeal examination and upper airway evaluation. We will discuss each of them in detail. First of all, general examination. In general examination, we'll see the general features, that is like obesity, any retrognathia means, as you can see in the picture, the mandible is somewhat backwards. You can see that it is labeled as gnathion and it is retro means that means back. So any retrognathia. We have to check the nose for any fractures of the nose. We have to see the ala for any ala collapse, and we have to rule out any conditions like acromegaly and also hypothyroidism. We should also check his body mass index, that is BMI. We have to check for neck circumference. If it is more than 17.5 inches in men or more than 16 inches in women, then it is a risk factor for obstructive sleep apnea, and there is indication that there is an obstruction in upper airway. Just a glance about clinical history. Now let's get into details of oropharyngeal examination. Before going to Friedman tongue position, I would like to add we have to check about size of tonsils, size of soft palate, laxity and position of the soft palate, any edentation, that is lack of teeth. We should also check these. And now Friedman tongue position is, we have to ask the patient to open his mouth and phonate. We are not keeping any tongue depressor over his tongue. Tongue is neutral over there. We are using these tongue positions to rule out which patient can undergo palatal surgery and who cannot. So in this picture, in first diagram, we can see the soft palate, fauces, uvula, anterior and posterior pillars, all are visible. So he is eligible for palatal surgery. And also in second picture, soft palate, fauces and uvula are still visible. So it can also be taken for palatal surgery. In class 3 and 4, soft palate and only base of uvula is visible. And in class 4, soft palate is also not visible. So Friedman tongue position 3 and 4 are not eligible for palatal surgery. And we have to rule this out in oropharyngeal examination only, so that we can opt who can get for palatal surgery and who cannot. Why we are discussing about palatal surgery, we will discuss in management video. This is clinical picture of all the 4 positions. And next is upper airway evaluation. We have to do upper airway evaluation by flexible fiber optic nasendoscopy as shown in the picture. So what we should examine here? We should examine nasal cavity for any deviated nasal septum DNS, any nasal polyps, any allergic rhinitis, any sinusitis, etc. And we have to also check for postnasal spaces, oropharynx and hypopharynx, any bulk of base of tongue, and also will perform Muller maneuver, and we'll discuss in next slides. Muller maneuver is exactly opposite to Valsalva maneuver. It is done by closing the mouth and breathing through nose. After that, we'll pinch the nose and keep it shut. Now Valsalva and Muller manual are completely opposite. In Valsalva, we will keep mouth open and also nose is closed. The picture here is Valsalva. Sorry that I couldn't get a good picture of Muller's manual, but if this is a small diagram before Muller and after Muller in case of airway narrowing in obstructive sleep apnea, and if it is a positive result, then it indicates that obstructive sleep apnea is present. But this is not perfect and accurate because wakefulness and sleep are different and there is variation in muscle tone which is significant. So we have to rely on special investigations, which along with management I will discuss in next video. This is all from Logan and Turner textbook of ENT. Hope you like this video. If you like this video, please do like, share and comment in the comment box. And also do subscribe to my channel Golden Dreams.